Hi, my name is William Chey. I'm the Chief of Gastroenterology and Hepatology at the University of Michigan in Ann Arbor, Michigan. And I've just spoken today at the Allied GI Conference in Jersey City. And I spoke about the clinical practice guideline, which was recently produced by the American College of Gastroenterology on the management of H. pylori infection. H. pylori infection remains a very important issue in the United States. The good news is that our prevalence of H. pylori infection is lower than in many other parts of the world, but still around 1 in 3 individuals in the United States are infected with H. pylori. So this is a very common infection, and it's one of the main causes of peptic ulcer disease. It's also been identified as a class 1 carcinogen for gastric cancer by the World Health Organization. There are a number of other important indications in which a doctor should think about testing for and treating H. pylori infection. So patients with dyspeptic symptoms, either uninvestigated dyspepsia or those with functional dyspepsia, also those with idiopathic thrombocytopenic purpura or unexplained iron deficiency anemia, individuals that are starting long-term therapy with a nonsteroidal anti-inflammatory medication or low-dose aspirin. Also, family contacts of individuals who have been diagnosed with H. pylori infection, if they're living in the same dwelling, might also want to be tested for H. pylori infection. And then finally, individuals with evidence of precancerous conditions on endoscopy, things like atrophic gastritis or intestinal metaplasia, should also be tested for H. pylori infection. A really important concept for people to be aware of is the fact that resistance of antibiotics or resistance of H. pylori infection to clarithromycin is rapidly increasing in the United States. In fact, the prevalence of clarithromycin resistance in the United States is now somewhere between 20 and over 30%. In addition, levofloxacin resistance, so quinolone resistance, is also approaching 40% in the United States. And for that reason, the ACG guideline recommends against empirically utilizing regimens that contain a macrolide or a quinolone to treat H. pylori infection. For individuals who are treatment naive, that is, diagnosed with H. pylori infection but not been previously treated for their H. pylori infection, the 3 main regimens to think about and to stick to include bismuth quadruple therapy containing acid suppression with a proton pump inhibitor or a PCAB, tetracycline, bismuth, and metronidazole. A second regimen is rifabutin triple therapy containing acid suppression, so a proton pump inhibitor, rifabutin, and amoxicillin. And a third regimen that's suggested by the guideline is the combination of a PCAB, a potassium competitive acid blocker called vonoprazan, with amoxicillin. All of these regimens should be given for a period of 14 days, and every patient who's treated for H. pylori infection should undergo a test to establish cure of the infection. So either a urea breath test, a fecal antigen test, or endoscopically based testing done at least 4 weeks after the completion of therapy. If an individual is found to have evidence of persistent infection, those main regimens that I talked about a moment ago are still going to be very important to think about. So bismuth quadruple therapy, rifabutin triple therapy, vonoprazan dual therapy, but are the main regimens that you're going to think about using, and you're going to try to use a regimen that is different than you originally used to treat a patient's H. pylori infection. In addition, if one does antibiotic susceptibility testing, which can either be done on tissue or stool with molecular testing, and a patient has been found to have an organism that's susceptible to macrolides or a quinolone, you can now also use regimens that contain clarithromycin or levofloxacin. So I hope those comments help you. Thanks for your attention and have a great day.